Assalamu alaikum, dear students, and welcome back to the second session on the subacromial impingement syndrome. Let's discuss what we have discussed in the previous session. So we started on the term subacromial impingement. That what is subacromial impingement? Then we discussed the internal and external types of internal rotation. We discussed then the two types of internal impingement: the posterior superior and anterior superior impingement syndrome. We discuss the different types of the impingement syndrome along with possible causes and its characteristic. After that, we discuss the subacromial impingement syndrome specifically and its history. Then its explanation or we can the definition from the literature. After that, the causes of the both the primary and secondary causes of the subacromial impingement syndrome. Then we discussed the internal glenoid impingement, which is the opposite type and which is opposite from the that external impingement or the interior impingement subacromial impingement syndrome. Why it is known as internal glenoid impingement, ये हमने discuss किया. Then we discussed the different mechanism involved in the subacromial impingement syndrome, both the intrinsic and extrinsic mechanism. We discussed the alteration in shoulder kinematic in shoulder impingement syndrome. We discussed the signs and symptoms and specifically the that painful arc, which is the pathognomonic of the subacromial impingement syndrome. Discuss the types and stages of the subacromial impingement according to the need. Then we discuss the two mechanism, the posterior capsule tightness and the rotator cuff insufficiency involved in the pathomechanism of the subacromial impingement syndrome. We discuss the upward and downward rotator. We discuss this GERD and the reaching up behind the movement. And now we will discuss the consequence of the in the patient in which they do not when they can't do the reaching up behind the movement. So that is just because they may have the abnormal movement of the scapula, and if there is abnormal movement of the scapula, that is termed as the scapular dyskinesia. So we will discuss what scapular dyskinesia is, and as well as its different types of the scapular dyskinesia. So the synchronous movement of the scapula with the arm is necessary for the execution of the normal humeral movement, specifically that a scapular humeral rhythm, which is 180. So if someone is going to elevate his or her shoulder and want to achieve then 180 degree of the shoulder elevation, so for that 180 shoulder elevation, we need that proper and normal synchronous movement of the scapula. Dysfunction of this synchronous movement of the scapula, if it is not present, so then that will be the patient will be unable to achieve that 180 degree of elevation, and this condition that is termed as the scapular dyskinesis. Non-specific response to a painful condition of the shoulder is a general elaboration of this term. In the shoulder pain, dyskinesis present is always present typical pattern during arm elevation, and that is the characteristic of that typical pattern is the delayed upward rotation, the posterior tilt, and the early internal rotation. Usually, जब हम elevation करते हैं तो वहां पर at 90 डिग्री से पहले पहले जो है हमारी upward rotation of scapula ये शुरू होती है. Similarly, the scapula जो है ये interior tilt होता है और वहां पे जो है बाद में जाके जो है ये internal rotation जो है ये issue आ जाती है. But the typical pattern of the scapular dyskinesia is कि when it is the upward rotation of the scapula is required, at that time there is no such upward rotation और बाद में आ जाती है. जब बाद में आ जाती है तो obviously उसकी contribution जो होनी चाहिए वो नहीं होती, and hence the person or we can say the patient will be unable to complete that 180 degree elevation. The reversal of this position of scapula significantly increases the subacromial spaces, and if this pattern is present, the delayed upward rotation, posterior tilt, and early internal rotation, so it will reduce the subacromial space, and hence it increase the chances of the subacromial impingement. So this is simply the scapular dyskinesis. We can see here on the this side, on exactly on the right side, there is some winging of the scapula, as well as you can see here, this shoulder is up to normal height, but we can see that there is some downward. The shoulder is some at downward down level than the opposite. So again, this is another characteristic of this scapular dyskinesia. Now we will discuss the type 1, 2, and 3. So in typically type 1 scapular dyskinesia, there is prominency of the inferior scapular border. जो दिस इज द मीडियल बॉर्डर एंड इसका जो लोअर पार्ट है ये प्रोमिनेंट होगा and there is abnormal rotation around a transverse axis. If this is the axis, so there will be abnormal rotation. And what does it mean when the patient is having this lower part of the that mid-scapular border elevation or prominency? It means there the patient is having the weakness of the lower trapezius, the weakness of the lateral latissimus dorsi, or the weakness of the serratus inferior. And most commonly, the serratus inferior is involved in this condition. Similarly, this condition may also be present when there is tightness of the pectoralis minor or major. The type 2, which is known as the classical winging, and this is in almost 90%, more than 90% cases, the serratus interior is involved. Um, in the previous type 1, वहाँ पर भी जो है serratus interior involved होती हैं, but वहाँ पे lower trapezius और latissimus dorsi की weakness भी जो है etiological factor हो सकती है for the type 1, but in the type 2, mostly the uh, serratus interior weakness is required. Why it is known as the classic winging? So in the type 2, there is prominence of the entire medial scapular winging. Entire medial scapular is prominent. There is abnormal rotation around the vertical axis. As we can see here, there is the entire medial scapular border is prominent. And this type 2, this indicates the weakness of the serratus interior, the weakness of the rhomboids, and the trapezius, all types of upper trapezius, middle trapezius, and the lower trapezius. In the type 3, there is prominence of the superior medial scapular border, as well as there is superior translation of the entire scapula. And this type of scapula that indicate the overactivity of the levator scapulae and the imbalance of the upper and lower trapezius sports couple. In type 3, that indicate the overactivity of the levator scapulae and as well as the imbalance of the between the two trapezius, the upper and lower trapezius. Usually, there is a balance between the fourth generation of upper and lower trapezius, but if there is disequilibrium or if there is imbalance between the production of force between the upper and lower, so and that may lead towards the superior translation or the superior prominency of that scapula. So the superior medial border जो है ये prominent होता है. So if we summarize these type 1 and type 2. So in the type 1, there is only the prominence of the that inferior medial scapular border, and the type 2, the prominence of the entire medial scapular border, and the type 3, there is only the prominence of the superior medial scapular border. Now, muscle flexibility in the chronic case of the subacromial impingement syndrome, usually muscles like the pectoralis minor, subclavius, levator scapulae, they all are tight and shortened, which contribute to the reduction of the subacromial space. Now, the second pathway which we will discuss is the insufficiency of the rotator cuff. The contraction of deltoid will cause the superior translation of the humeral head, while the rotator cuff and the long head of the bicep, they will act in the opposite direction of this deltoid, and they will counterbalance the translation and will rotate the humeral head within the glenoid cavity. If there is failure of the rotator cuff, so obviously there will be prominency, there will be dominancy of the deltoid, and this rotator cuff failure, they will allow the superior translation and the repeated movement, and that का will cause injury to the rotator cuff tendon. Because जब डेल्टाइड की डोमिनेंसी हो जाती है जो सुपीरियर ट्रांसलेशन कर लेता है और रोटेटर कफ जो कंप्रेशन या इस तरह का हम कह सकते हैं कि दे विल कीप द humeral head inside the glenoid cavity. ये actually अगर if there is failure of this counterbalance, so obviously the deltoid action will be more, which is the superior translation of the humeral head. और जब superior translation ज्यादा होगी, so obviously there will be injury to the rotator cuff tendon, the supraspinatus. इस साथ साथ जो है इसके जो दूसरे स्ट्रक्चर्स विच आर आल्सो प्रेजेंट इन दिस स्पेस, उनको भी इंजरी के चांसेस है, डैमेज होने की चांसेस है, लॉन्ग हेड ऑफ द बाइसेप एंड द सबक्रूमियल पर्सा. क्योंकि इस ये जो क्रूमिन के नीचे जो स्ट्रक्चर्स होते हैं, there are total 6 structures present between the humeral head and the acromion, and if there is increased translation of the humeral head and there is no such counterbalance or not enough uh, counterbalance, yeah, we can say that the insufficient counterbalance of the rotator cuff against the deltoid, since there will be imbalance of this force movement, and there will be more superior translation, which will lead to the impingement of the structures between these two osteostructures, most commonly the subtendon of the supraspinatus, the tendon of the long head of bicep, and the subacromial bursa. और इस तरह फिर ये कंटिन्यू हो जाती है, क्योंकि जब एक बार इसकी इम्पेचमेंट हो जाती है तो इसकी वजह से दे विल बी मोर एंड मोर डोमिनेंसी ऑफ द deltoid because of the more and more insufficiency of the rotator cuff. और इस तरह जो है ये साइकिल जो है ये कंटिन्यू हो जाते हैं, यानी जो because of the rotator cuff failure there will be injury to the rotator cuff, which will again lead towards the more dominancy of the deltoid, will lead to more translation of the humeral head, will lead to more and more damage to the long head of bicep tendon, supraspinatus tendon, and the subacromial bursa. And the outcome of the repeated injury may be partial or the full thickness of the tear. Now, what are the third pathway, the anatomical anomalies and the degenerative changes? Usually, when there is the stenosis of this space between the humeral head and the acromion, so that is actually present after some abnormal anomalies. The normal space is between 1 to 1.5 centimeter, and normal human translation is up to 5 mm. So insignificant translation compared to available insignificant translation compared to available space. So that's why the scapular movement is very, very important during the translation, superior translation of that humeral head. So scapular dyskinesis and the resultant acromion tipping combined with the subacromial structure and acromion anomalies, they will all lead towards that stenosis of that space, or they will be lead towards the little room, and that condition is known as the little room. The decreased space are the narrowing of that suprahumeral or the subacromial space. Now, as we have discussed in the previous session, that subacromial impingement syndrome is not actually a single disease. It is a group of pathology. It is a group of disease, and that the disease may require. They may include the capsule. They may include the tendon. They may include the ligament. They may include the different tendons. They may also include the bursa. So the sources of that pain in the subequilibrium that depend on what is actually the pathological structure involved in this condition. So these depend on them. That may include the tendonitis or the tendinosis of the rotator cuff tendon. That may include the source may be from the tendonitis of the bicep long tendon. The source of pain is just because of the subacromial bursitis. The source of the pain is that maybe because of the deltoid muscle or the subdeltoid bursa. Similarly, the biliary supraspinatus and infraspinatus subsepals may be also involved. The pain may be because of the rhomboid insufficiency, the serratus inferior weakness. Is ये जो rhomboids and the serratus inferior weakness, they all will lead to the scapulodyskinesis और and scapulodyskinesis की वजह से वहाँ पे जो एलिवेशन ऑफ द स्किपुला या एलिवेशन ऑफ द इक्विपमेंट ये नहीं होगा तो ह्यूमरल हेड इंक्रीज स्पीड के साथ ये नहीं जाएगा, वो अपने नॉर्मल ट्रांसलेशन के साथ जाएगा। लेकिन क्योंकि वहां पर इक्विपमेंट की एलिवेशन नहीं होगी तो स्पेस जो है ये स्टेनोसिस सिचुएशन में आ जाएगा, हेंस देयर विल बी इंगेजमेंट ऑफ द स्ट्रक्चर्स। इसी तरह जो है ये सेरेटस इंटीरियर रॉम्बॉइड्स और ये जो मसल्स है स्किपुलर मसल वीकनेस जो है ये indirectly जो है are the causes of the that impingement syndrome. Adhesion between the fascia and the PCT and the neurogenic pain and all of the above भी हो सकते हैं। So this is actually the complex interaction between the different different events और जैसे हमने कहा कि ये एक vicious cycle है कि again if A is causing the B and B is causing the A and A is causing again the B, so इस तरह ये cycle जो है ये चलता रहता है। मिसाल के तौर पर if we have the posterior or inferior capsule tightness and most commonly if there is the posterior capsule tightness, so it will lead to two situation. या तो यहाँ पे पोस्टीरियर कफ जो रोटेटर कफ टेंडन है उसके डिस्फंक्शन होगी या वीकनेस होगी या इस पोस्टीरियर कैप्सूल टाइटनेस की वजह से यहाँ पे स्किपुलर डिस्काइनेसिया हो सकती है। और यहाँ पे जब पोस्टीरियर स्किपुलर डिस्काइनेसिया हो सकती है सो अगेन इट मे लीड टुवर्ड्स द अल्ट्रेशन इन द फोर्स कपल या जो है इट मे दिस स्किपुलर डिस्काइनेसिया विल लीड इनटू द रोटेटर कफ dysfunction or the weakness of the rotator cuff, or we can say that the insufficiency of the rotator cuff. और अगर ये फोर्स कपल जो है अल्ट्रेशन काज कर लेता है so it will lead to the pain and relative immobility, specifically the limitation in the internal rotation, and as well as this alteration of force couple will lead to the rotator cuff dysfunction. ये जो रोटेटर कफ इंसफिशिएंसी है डिस्फंक्शन है या इसको हम जो इंसफिशिएंसी कह सकते हैं ये दोबारा जो है ये पोस्टीरियर कैप्सूल टाइटनेस काज कर सकता है और साथ साथ जो है ये जो ट्रांसलेशन ऑफ द ह्यूमरल हेड है उसको भी जो है ये एनहांस कर सकता है। जिसे हमने पिछले डिस्कस किया कि क्योंकि रोटेटर कफ जो है ये डेल्टाइड के अपोजिट काम करते हैं। इफ देयर इज वीकनेस और द failure of the rotator cuff dysfunction, so they will be increase in the interior superior translation of the humeral head. इसी तरह अगर फोर्स कपल जो है बिटवीन द डिफरेंट मसल्स ऑफ द शोल्डर एंड स्किपुला अगर वहां पे अब जो फोर्स कपल अल्ट्रेशन हो जाती है उससे भी जो इम्बैलेंस क्रिएट होगा और उस इम्बैलेंस की वजह से दे विल बी इंक्रीज इन द सुपीरियर ट्रांसलेशन ऑफ द ह्यूमरल हेड। अगर यहाँ पे जो if there is more superior translation of the humeral head और साथ साथ यहाँ पे स्किपुलर डिस्काइनेसिस भी है यानी स्किपुलर जो है ये अपर रोटेट नहीं हो रहा है, डिलेड अपर रोटेशन है, पोस्टीरियर टिल्टिंग है एंड अर्ली इंटरनल रोटेशन हो जाती है, in that case there will be reduction in the subecular space। यानी यहाँ पे ये जो स्पेस है इसलिए रिड्यूस हो रहा है कि एक तो यहाँ से जो ह्यूमरल हेड है ये सुपीरियर ट्रांसलेशन उसकी ज्यादा हो रही है बिकॉज ऑफ द डोमिनेंसी ऑफ द दैट डेल्टाइड एंड एज अ रिजल्ट ऑफ द इनसफिशिएंसी ऑफ द रोटेटर कफ, तो इसकी वजह से ट्रांसलेशन ज्यादा हो रही है और उधर से अपोजिट जो सुपीरियर मूवमेंट ऑफ द इक्विपमेंट ये भी नहीं हो रही है। तो इन बोथ केसेस व्हेन द स्किपोडिस्काइनेसिया or the insufficient movement of the scapular abnormal जो synchronous movement है ये नहीं हो रही है और साथ साथ superior translation भी ज्यादा हो रही है, तो इन दोनों की वजह से क्या होगा there will be stenosis of that subequial space, reduction in subequial space. अब सब इक्विलिब्रियम स्पेस की ये दोनों रीजन सिर्फ नहीं है, ये रीजन जो है ये सब स्पेस जो है फंक्शनल काजेस के साथ साथ जो है ये एनाटॉमिकल जो स्ट्रक्चर्स जो एनाटॉमिक स्ट्रक्चरल डिफरेंस जो है उसकी वजह से भी जो है ये स्पेस कम हो सकती है। लाइक एक टाइप 3 इक्विलिब्रियम है, लाइक स्पर है एज टू एथलेटिक चेंजेस की वजह से, या देयर इज डीजेनरेशन ऑफ दिस डिफरेंट बोन स्ट्रक्चर्स जिसकी वजह से देयर इज वियर एंड टियर, या यहाँ पे कैल्सिफिकेशन हो अब द टेंडन हो गई, कैल्सिफिक टेंडनाइटिस है, या पोस्चर प्रॉब्लम है, इन तमाम की वजह से भी जो है स्पेस जो है ये रिड्यूस होगा। और जब स्पेस रिड्यूस होगा सो देयर विल बी इम्पेजमेंट ऑफ द bursa, there will be impingement of the lanyard of the bicep tendon, and there will be the impingement of the that supraspinatus tendon. Similarly, if there is sports couple alteration, so because of that imbalance between the different muscles of the scapula and shoulder, इसकी जो है चार रिजल्ट्स होते हैं। ये जब sports couple alteration होती हैं, so it will lead to the rotator cuff insufficiency or dysfunction or weakness. It will lead to the increased translatory moment, anterior superior translatory moment of the humeral head. It will also lead to the subacromial impingement and this alteration moment, and as well as it will be a source of the pain as well. तो अगर ये डायरेक्ट सोर्स भी दे सकता है बिकॉज ऑफ द ओवर एक्टिविटी ऑफ द मसल, बिकॉज ऑफ द इम्बैलेंस ऑफ दीज मसल्स, as well as it can cause the pain because of the impingement of the structure. So you don't know, it's cases where we can say that it may be the direct source of the pain or it may be the indirect source of pain as it will cause the subacromial impingement and later the subacromial impingement will be the source of pain. इसी तरह अगर स्पेस डिक्रीज हो जाती है बिकॉज ऑफ द स्क्लेरोडिस्किनेसिस और बिकॉज ऑफ द इंटीरियर superior humeral translation or because of the anomalies of the acromion spur where anterior calcification or posture, in तमाम की वजह से there will be subacromial impingement which will lead to the pain and relative immobility. और जब पेन भी है और साथ साथ लिमिटेशन ऑफ द रेंज ऑफ मोशन है, तो इस immobility की वजह से और पेन की वजह से स्पेसिफिकली immobility की वजह से there will be more and more posterior and inferior capsule tightness. He will be more and more because of the immobility, because of the pain. There will be more and more rotator cuff dysfunction and or weakness. और इसी तरह ये तमाम प्रोसेस दोबारा से रिपीट होगा. So that's why this is a vicious cycle. Vicious cycle उसको कहते हैं कि जिसमें से जैसे हमने कहा कि A is causing the B की वजह से A होता है और A दोबारा B को कस कर इस तरह ये चलता रहता है जब तक इसको ट्रीट नहीं किया जाता. सो बिकॉज अब ये जो विशियस साइकिल के इसमें posterior capsule tightness and the rotator cuff insufficiency, they will lead to subacromial impingement and the pain and more immobility, and they will again lead toward these two situations which will further increase and enhance the symptoms of the patient. So that is a complex interaction of the key components in the that vicious cycle of the subacromial impingement syndrome. These are the different muscle group. This column is their normal muscle action, but when there is alteration in these action of these muscle, so what will be the clinical effect? If we discuss the anterior deltoid, so its normal action is the mostly the flexion of the shoulder. It also help in the internal rotation. जब उसकी ओवर डोमिनेंस हो जाती है, जैसे हमने डिस्कस किया प्रीवियस स्लाइड में कि इंटीरियर डेल्टाइड और रोटेटर कफ एक दूसरे की अपोजिट काम करते हैं, इक्वली काम करते हैं, यानी देयर मैग्नीट्यूड ऑफ फोर्स प्रोडक्शन इज इक्वल इन मैग्नीट्यूड बट अपोजिट इन डायरेक्शन. अगर यहाँ पे मैग्नीट्यूड इम्बेलेंस हो जाती है तो इसका वजह ये हो सकती है कि रोटेटर कफ जब वीक हो जाएगा, इनसफिशिएंसी हो जाएगी, तो ऑब्वियसली जो फोर्स प्रोडक्शन है, मैग्नीट्यूड है अब द डेल्टाइड, ये ज्यादा हो जाएगी. तो ये ओवर डोमिनेंस जो है इसकी बिकॉज ऑफ द रोटेटर कफ थिकनेस की वजह से इससे पूरा जो ग्लेनोह्यूमरल मैकेनिक्स है ये जो है डिस्टर्ब हो जाएगा, ये चेंज हो जाएगा, और जिसकी वजह से दे विल बी This urodominance, which when it alters the joint mechanics, it will lead to the interior human translation and the subacromial impingement syndrome. Similarly, if we talk about the posterior deltoid, so its main action is the extension and external rotation. But when this posterior deltoid is dominant, so that dominant firing pattern may cause the posterior tightness, and which will lead to the tightness of the posterior capsule. And this posterior capsule may then lead to the scapular kinematics. Similarly, the middle deltoid, which is the primary abductors, and again, just because of the weak supraspinatus ischio dominancy, because supraspinatus is also abductor. If there is weakness of the supraspinatus, so obviously there will be more activity by the deltoid, so there will be urodominancy, and the urodominancy हो जाती है then normal, so they will lead to superior human head migration, and उसकी वजह से they will be decrease in the subecular strength in which will lead to the impingement. So overall यहाँ पे अगर हम देखें muscular causes जो है muscular imbalance है, they will lead towards the subecular impingement syndrome and different mechanism. Serratus interior, and its main function is the protection, upward rotation, and posterior tilting of the scapula. And when it is weak, so it will lead to the winging. That is the classical winging, type 2 winging, and there will be poor upward rotation because इसका मेन एक्शन क्या है, दैट इज अपर रोटेशन. अगर इस सेरेटिस इंटीरियर है ये वीक हो जाता है, सो अपर रोटेशन विच इज रिक्वायर्ड इन द नॉर्मल एलिवेशन ये नहीं होगी, तो obviously that will lead to scapulodyskinesis, and that scapulodyskinesis will lead to the impingement as well as to the shoulder instability. Similarly, the upper trapezius, which is the upward rotator muscle, as well as it is the elevator of the scapula of the shoulder. So, if there is no activity without, yeah, if there is imbalance between the trapezius, as we have discussed in the previous slide, that some of the causes between that uh, so that is the imbalance between the concentrically activated agonist and eccentrically activated agonist. ये जो imbalance है, that is one of the causative factor behind this cervical impairment syndrome. और इसकी वजह से जो है यहाँ पे ये जो imbalance है between the upper the elevator of the scapula and the depressor of the scapula, uh, यहाँ पे हो जाता है shoulder impingement syndrome. अच्छा, तो so जब वो एक्टिविटी हो जाती है, so obviously there will be early scapular elevation, and similarly there will be scapular dyskinesia. Lower trapezius जो है इसका main काम जो है, this is the scapular depression, but as well as it is upper rotator as well along with the that upper trapezius. So weakness of the lower trapezius that will lead to the um, impairment in the upward rotation and as well as the posterior tilting, which will lead to the loss of scapular control, and that will increase the risk for the impingement syndrome. The rhomboids, which is a basically retractor and as well as it is a downward rotator, if there is tightness of this muscle, they will restrict the upper scapular rotation and they will be poor overhead motion mechanics. So इन तमाम जितनी भी ये मसल ग्रुप है उनका जो when there is alteration in the force couple, so obviously they all will lead to the directly into the impingement syndrome, or they may lead to some clinical effect which will cause the different the mechanism for the subacromial impingement. So these force couple movement, they may be involved directly in the subacromial impingement syndrome, or they may just cause the and without causing the subacromial impingement, and subacromial impingement may be because of the different other causes as well. So ये जो force couple alteration है, ये तमाम alteration है, ये जो है this is mostly involved directly or indirectly in the subacromial impingement syndrome. These are the normal range of motion. This is the assessment of the forward flexion. The arm will be straight and brought upward and moves as far as the patient can go above his or her head. 0 degree is defined as straight down, or it is considered as the stereo position, neutral position, and the patient side, and 180 is the straight up. The abduction, the arm will be straight, hand palm up, supinated, range of measure in the degrees as far as the uh, forward flexion. These are the different tests, the flexion and extension test. The muscles, the anterior deltoid and posterior deltoid. Here is the scapula would be स्टेबलाइज्ड, ताकि उसकी डिविएशन या पोस्टीरियर मूवमेंट ना हो, जबकि पेशेंट जो है ये इनिशियली उसको थोड़ा सा हम मिड रेंज में लेके जाएंगे, फिर इसको हम रेजिस्टेंस देंगे एंड पेशेंट से कहेंगे कि आप इससे आगे जो है शोल्डर फ्लेक्शन करें. तो जब इनिशियल हम इसलिए करना चाहिए कि हम हमेशा से वी शुड स्टार्ट फ्रॉम द ग्रेड 3 if the patient can do uh, movement without resistance against the gravity, तब जाके हम रेजिस्टेंस जो है ऐड कर सकते हैं. तो इस पोजीशन से देखिए कि the shoulder will be just the stabilizing hand will be just on the posterior superior aspects of the shoulder, and the distal humerus, the resistance hand will be on the interior side of the distal humerus, और वहां से पेशेंट की फ्लेक्शन है ये थेरापिस्ट रजिस्ट करेगा. Therapist will try to bring that humerus back to that neutral position, and the patient will try to bring it in the forward up to the 90 degree. Similarly, in the extension, the therapist will try to bring it back to neutral position, and जबकि patient कोशिश करेगा या करेगी to bring it in that posterior direction. So that is actually the flexion and extension strength of the interior and posterior deltoid. The empty can test, the left top test, the empty can test is used for the assessment of the supraspinatus, and left top test they are used for the subscapularis. You already know how to conduct and how to perform these tests. Actually, इस टेस्ट में we can see here there is shoulder extension involved होगी, elbow flexion involved होगी, और पेशेंट्स को कहा जाएगा कि आप जो है अपने हाथ को अपनी बैक से उठाएं, यानी आप इसको थोड़ा सा बैक से उठाएं, and therapist will try to keep that hand attached with the back of the patient. So that's why this is known as the left up test. If the patient has normal subscapularis, तो somehow some maximum resistance के साथ वो अपने hand को lift करेगा. These are the strength test for the infraspinatus teres minor and the subscapularis. These two are the external rotator and the subscapularis the internal rotator. There is the knee sign. Patient seated or patient can be in the standing position with arm at side, palm down pronated, which is also known as the empty can test. Examiner standing, examiner stabilize the scapula and raise the arm between the flexion and abduction. If there is pain at this internal patient, we can see here the patient will initially in the empty can position, and फिर patient से कहा जाएगा कि आप thumb को जो है toward the ceiling से आप ground की तरफ लेके आए. So usually वहां पर क्या होगा, supination से pronation होगी. जब pronation हो जाएगी, so the arm will the thumb will be towards the ground और इंटरनल रोटेशन हो जाएगी, यानी फोर आर्म की सुपिनेशन से प्रोनेशन पे जाएगी, जबकि शोल्डर पे दे विल बी इंटरनल रोटेशन, और इससे अगर पेशेंट को पेन होता है, so that will be a positive sign for the subacromial impingement. This is the Hawking test. इसमें सिर्फ previous test में the elbow will be straight, and this test the elbow will be bent, there will be flexion of the elbow. Patients को internal rotation कराया जाएगा, and if there is pain on the internal rotation in this position, So that will again indication of the subacromial impingement syndrome. मेडिकल इमेजिंग इसमें इम्पोर्टेंट हम रेडियोग्राफ यूज कर सकते हैं that what is actually the position of the humeral head during a specific position. साथ साथ हम जो है अल्ट्रासाउंड यूज कर सकते हैं फॉर द टेंडन टीयर्स is MRI यूज कर सकते हैं if there is suspicious the patient is suspicious for some tendon tear or the joint effusion of the intraarticular abnormalities. चूंकि ये subacromial syndrome जो ये एक डायनामिक कंडीशन है that's why there is no such pathognomonic medical imaging indicators that if they are present they will surely indicate the presence of the subacromial impingement syndrome. हम इंटीरियर पोस्टीरियर रेडियोग्राफ जो है यूज करते हैं और उसमें मोस्ट इम्पोर्टेंटली हम चेक करते हैं द एक्रूमियल इंडेक्स को. नाउ व्हाट इज द एक्रूमियल इंडेक्स? एक्रूमियल इंडेक्स जो है एक स्ट्रेट लाइन हम ड्रॉ करेंगे एंड दैट स्ट्रेट लाइन विल फ्रॉम द superior granite tubercle till the inferior granite tubercle, and hence a straight line will be drawn on the lateral surface of that humerus. Then the distance will be made between the glenoid line and the lateral humeral line, and that is known as the GH line. And another line which will be passed through the lateral boundary of the acromion, and this distance between that glenoid line and this acromion line. This is the acromion line, this is the humeral line, this is the glenoid line. So the GA mean the distance between the acromion line and the humeral line, while the GH distance that means the distance between the glenoid line and the humeral line. And then the ratio of the GA to the GH, yeah, GA divided by GH, the answer will be called as the acromial index. So the acromial index is the ratio between the distance from the glenoid and the lateral edge of the acromion and the distance from the glenoid and the lateral edge of the greater tuberosity of that humerus. The normal value is 0.64 in asymptomatic patient. If it is larger, yani 0.73, suppose they are more than 73, so that is indication of the rotator cuff tear. And if it is less than zero point 0.6, if it is zero point 0.6 or less than zero point 0.6, so it is indication of the osteoarthritic changes in the shoulder. So this is important. The AI, what is the normal value of the AI? And if the value is more than the normal, so it indicates the subacromial impingement. The another aspect of which we can be assess the shoulder, which we can assess the shoulder from that anterior posterior radiograph of the shoulder is the TSA, which is the critical shoulder angle. TSA is the angle between the glenoid axis and the line through the inferior edge of the glenoid and the lateral extremity of the acromion. We can see here, this is the glenoid axis of the glenoid line, and then another line is drawn from this glenoid axis to the lateral part of this acromion. So the lateral extremity or the lateral boundary or the lateral end of this acromion, and this angle which will be made between this line and the glenoid axis, they will be called as the uh, critical shoulder angle. The critical shoulder angle normal value is 33, and if it is more up to the 35, it is considered as normal. But if it is more than 35, then it is indication of the tear among the rotator cuff tendon. And up to the 30, again, there may be it is considered as normal. But if it is less than 30 degree, then again there is indication of the osteoarthritic changes in the shoulder joint. Similarly, another aspect of this which we can assess is the lateral angle of the acromion, and this is the angle between the glenoid axis and the inferior slope of the acromion. We can see here this is the glenoid axis, the line drawn from the that lateral end of the superior glenoid tubercle and inferior glenoid tubercle, or we can say that the on the long axis that a line drawn on the axis of the vertical axis of the granite, and then a line is drawn on the under surface of the equilibrium, and the angle made between these two lines will be considered as the lateral angle of the equilibrium. And if this angle is less than the normal, so that will be a restrict for the tendinopathy of the or the tear of the rotator cuff tendon. इसी तरह एक्सरे जो है ये हम उसमें हम ये भी देख सकते हैं कि if there is calcification of the tendons, specifically supraspinatus tendon is more prone towards the calcification, and we can see here there is a cloudy appearance in that, and that is actually the supraspinatus tendon, calcific tendonitis. So the calcific tendonitis of the right shoulder in a 26-year-old woman, the patient report intense pain and in the symptomatology reason for the accumulation of the calcium in the tendon of the that supraspinatus. The MRI scan, high signal areas in the subacromial bursa. So this MRI can be used to assess the tendon tear. This can be assessed for the assess the subacromial bursitis, or that can be assessed intraarticular changes. Similarly, it can also be used to assess the rise bodies, and these are the small granular bodies that can be seen in the inflammatory arthritis and infective arthritis like tuberculosis or the arthritis. Similarly, the MRI can also be used to assess the gap between the humeral head and that acromion. The gap between the acromion and the humeral head, they should be greater than 7 mm. Like in this case, that is 7.2 mm, so it is a normal space. If that space is less than 7 mm, so this is a stenotic space, and in this case, there is more chances of the subacromial impingement syndrome. If there is the type 3 acromion, so then it will lead towards the more chances of the subacromial impingement. Similarly, the MRI can also be used to assess the calcific tendonitis, because we can see here this is the humeral head and this is the tendon of the supraspinatus, and this is a gray in color, but we can see a black spot, and that flux is actually the calcification or the calcific deposition inside the tendon. So that might be the cause, and they may lead towards the uh, supraspinatus tendonitis, or which is known as the calcific tendonitis, and which will eventually lead to subacromial impingement. So this is actually the basic treatment for the calcific tendonitis is just to removal of this calcific deposition. And if these deposition, calcium deposition, if they are uh, and if they live untreated, so they may lead to the later on degeneration. So somehow there are two types of the calcification. One is known as the reactive calcification, which may be because of the overactivity or the imbalance of them in between the rotator cuff muscles and the other scapular muscles. And the other is the degenerative calcification, which is the age-related problem, and there is no such force alteration, or if there is no imbalance between the different muscle involved. So there is known it is known as the degenerative calcification. Similarly, the MRI or the radiograph both can be used to assess the osteophyte. As we can see here, a hook under a pointed large osteophyte just under the surface of this acromion. Just this is the humeral head. This is the subacromial space, and this extremely large osteophyte in the lower surface of the acromion creates intense pain and subacromial impingement syndrome. Uh, large osteophytes which produce from the lower surface of the clavicle and injure the supraspinatus tendon, creating a similar pain syndrome, can be seen through the arthroscopy, and not only seen and diagnosed through the arthroscopy, but it can be treated through the this arthroscopy. The conservative treatment, most patients with the primary impingement can be successfully treated without the surgery. A conservative treatment should be tried first in cases where significant mechanical causes such as large osteopathy have been excluded. Because if there are large osteopathy, if there are spurs on these areas, or if there is the type 3 hook equipment, so obviously then there is no such benefit of the conservative treatment, and the surgical intervention is the only ऑप्शन बिकॉज जब तक उसकी जो एक्सेशन हम नहीं करते ये उसकी क्रूमिंग की जब तक ये जो स्पर को रिमूव नहीं किया जाता तब तक जो है ये देयर विल बी द प्रॉब्लम विल बी कंसिस्टेंटली प्रेजेंट एंड हेंस द ओनली ऑप्शन इज द सर्जिकल इंटरवेंशन अगर ये चीज ही नहीं है जस्ट द रीजन बिहाइंड द मैकेनिज्म इज जस्ट functional causes है the imbalance between the muscles है force alteration है या बाकी इस तरह की जो है biomechanical reasons है so they can be treated through conservative treatment without any surgical intervention. Rest from those activities that exacerbate the symptom, specifically those activities which involve elevation and internal rotation of the shoulder, that is more important in the conservative treatment. Similarly, the NSAIDs they can also give temporary relief, specifically in the if there is tendonitis in the patient, or if there is bursitis. So in that case, NSAID can help in the reduction of the pain and swelling. Physical therapy and the other cortisone injections they can be also included in the conservative treatment. These are the cortisone injection, which is the procedure used for the injection of that cortisone at that shoulder area. In the physical therapy treatment, we can include the stretching of the posterior capsule, and we can do through the two um, very common approach to stretch the posterior capsule is the across the body stretch or the sleeper stretch. The sleeping stretch is the very effective and relaxing and releasing the tightness in the posterior capsule. Similarly, we can include the stretching of the pectoral minor and major. These two muscles they are commonly induced very tight in the subacromial impingement syndrome. Similarly, we can also include the rehabilitation for the serratus anterior. In most of the cases, it may be the weak, but we can give the strengthening of the serratus anterior, and if it is the serratus anterior, if it is tight, so we can include it in the stretching category. Similarly, we can work on the rotator cuff facilitation and through the PNF as well and through the non-PNF stretching as well. And because of this, the imbalance will be treated. And if there is the reconstruction of the balance between the rotator cuff tendon and the deltoid, so obviously there will be a reversal of the alteration of the force couple, and hence there will be indirect treatment of the subacromial impingement. Posterior wall adhesion, mobilization, manipulation, scapular movements of mobilization, regularization, the capillary exercise for the scapular control, co-contraction exercises, transverse friction, and electrotherapy, tapping in it. All these options here can be used to treat and to include in the plan during that conservative treatment. So this is one of the tapping procedures used for treating the subacromial impingement syndrome. This is the scapular inner tapping to treat that scapular dyskinesis. These are the capillary exercises, also known as the open book exercises. Usually, the capillary exercises are the open book exercises uh, that they are used to stretch the interior muscle, especially the pectoral muscles. This is the sleeper stretch, which is used to release a stretch used to release the posterior capsule tightness, and it is very effective. This sleeper stretch that should be added to in the rehabilitation when it is the subacromial impingement syndrome, if there is the adhesive capsulitis as well, because in that condition there is maybe also posterior capsule tightness. This is the sleeper stretch. Patient will be in the lying position and the shoulder which is unaffected उसका जो हाथ है ये उसकी डिस्टल फोरम की डॉर्सम पर रखेगा और फिर इसको नीचे की तरफ पुश करेगा अगेन एंड अगेन. That will lead to the stretching of the posterior capsule. That can be, this is known as the Loro exercises. Again, it is used just to strengthen the serratus interior as well as to the lower trapezius. As these two muscles, because one of the reason which we discussed behind this, that subacromial syndrome is the trap imbalance. So with this exercise, we can also strengthen the lower trapezius, and if the lower trapezius is, if there is rehabilitated, so obviously then the imbalance situation between the upper and lower trap will be eliminated, which will lead to the indirect treatment of the subacromial impingement. So in दोनों में जो imbalance होती है, so usually there is over dominance of the upper trapezius and the lower trapezius become weak. इसी तरह जो है ये सेरेटस इंटीरियर इंटीरियर सेरेटस इंटीरियर जो है, इसकी भी वीकनेस की वजह से स्किपुलर विंगिंग होगी. स्किपुलर विंगिंग की वजह से वहां पे स्किपुलर मैकेनिकल जो मूवमेंट इन्वॉल्वमेंट रिक्वायरमेंट मूवमेंट वो नहीं होगी, जिसकी वजह से वहां पे डिक्रीज इन द स्पेस होगा, और डिक्रीज स्पेस की वजह से दे विल बी इम्पेजमेंट ऑफ द सबक्यूमेंट स्ट्रक्चर्स. So इसलिए if this low row should exercises, that should be added along with the other exercises in the treatment, the conservative treatment of the that subacromial impingement syndrome. These are the different diagonal trunk rotation, scapular rotation mean, and these exercises, the PNF exercises, they are very helpful in attaining the balance between the scapular muscles. This exercise is known as the scapular clock exercise, and again, it is very helpful in the achieving back and reversal of the alteration of the scapular muscles. It is also used to treat the scapular dyskinesis. This is the horizontal close chain exercises, and again, it is used to assist that and to achieve that range of motion of the shoulder. Vertical close chain exercise. This is the horizontal close chain exercise, and this is the vertical close chain exercises. Cordman exercises, और वहाँ पे ये अपने हाथ में थोड़ी बहुत वजन भी रख सकता है, which will involve the circumduction or the rotation with the hand supported on the that ball. These are the other different exercises which we can include the TheraBand as well as we can include the weight in the internal and external rotation. Just because the internal external rotation की दरमियान भी जो है वहाँ पे जो internal rotators है वो ज्यादातर उस पर डोमिनेंसी होती है as compared to the posterior rotators. सर्जिकल ट्रीटमेंट में देन द एक्रोमियोप्लास्टी की जो इक्रोमियन हुक टाइप होता है, या वी कैन से दैट द टाइप 2 है या टाइप 3 है, इन बोथ केसेस जो है उसकी सर्जिकल एक्सेशन हो जाती है, सो दैट सर्जिकल ट्रीटमेंट सर्जिकल रिमूवल ऑफ द दैट एक्रूमियन इज नोन एज द एक्रोमियोप्लास्टी. इसी तरह आर्थ्रोस्कोपिक सब एक्रूमियल डिकम्प्रेशन है व्हिच वी हैव डिस्कस्ड इन डिटेल इन द प्रीवियसली. When non-surgical treatment that does not relieve the pain following at least 6-month trial, then there is recommendation of the surgical intervention. The main goal of the surgical intervention is to remove the impingement and create more space for the rotator cuff. So if there are spur, if there is calcification, if there is the debris because of that wear and tear, and if there is the abnormal hook type, the equipment, so all these they can be treated through surgery, and and after that they will be increase in the space. This allows the hemorrhage to move freely because the space will be more, and there will be more and more equipment subequipment space, and then there will be no such pain. The most common surgical treatment is the subequipment decompression or the anterior acromioplasty. This may be conducted by the arthroscopic technique. So that is actually the B chair position used for the shoulder arthroscopy. That is the procedure for the shoulder arthroscopy acromioplasty. That is the osteophyte removal of that with that special bore. It is the removal of that extra or abnormal acromion. These are the different literature um, which indicate how much the conservative treatment is effective in the subacromial impingement. So stretching exercises for the subacromial impingement syndrome, effect of 6-week program on shoulder tightness, pain, and disability status. And the conclusion of the study was that finding of the study showed that flexibility, pain severity, and disability gain can be achieved with a 6-week stretching exercise training for patient with subacromial impairment syndrome. Therefore, shoulder girdle stretching exercise should be recommended early in the shoulder rehabilitation program in the conservative treatment. Comparison of the virtual reality exergaming and the home exercise programs in patients with subacromial impairment syndrome and scapular dyskinesis. And according to this study, the virtual reality exergaming programs with these programs were found more effective than the home exercise program at short term in subjects with the subacromial impairment syndrome. Both the SIS, the shoulder impingement syndrome, or the subacromial impingement syndrome. SIS and the SAIS, both abbreviations, they are common in the literature and both are correct. You can use the SIS, which means the sub, and A mean acromial impingement syndrome, or you may use the SI, which mean S mean the subacromial, and I mean the impingement, and S mean that syndrome. And SIS is also used for the shoulder impingement syndrome. The comparative efficacy of the kinesitaping and local injection therapy in patients with the subacromial impingement syndrome. And the conclusion of this study was that although the improvement in pain intensity at rest range of pain stability were better with the local injection, kinesitaping may be an alternative in non-invasive method to local subacromial impingement for patients suffering from the subacromial impingement syndrome. So if there is unavailability of that local anesthetic or local injection. So the kinesio taping or the KT, the taping can also be used to treat the acute subacromial impingement syndrome. There is another study, and that is the end of today's session. Thank you so much to all of you.